Thank you. You have heard of intraoperative navigation so far. As you are aware, there are two types of navigation, fluoroscopy and the CT-based navigation. It could be either intraoperative or preoperative. What we use nowadays is intraoperative navigation system. As you heard so far, navigation is typically used for pedicle screw placement in various cervical spine complex surgeries, revision surgeries. It has been also extended to be used in situations to identify the ossified ligamentum flavum. It makes it much easier in a complex scenario, as you heard Dr. Sailesh speak about. What is the role of navigation in spinal tumors? The role of navigation in spinal tumors is basically to identify the tumor mass, define the tumor margins, and control the excisional procedures. Therefore, it depends whether the lesion is a benign or a malignant tumor. In the benign tumor, the aim is intralesional resection, whereas in a malignant tumor, it helps to do the gross total resection. As we are aware, the benign tumors can be bony, cartilaginous, and vascular. The post-element tumors are the osteoblastoma and the osteoblastoma most commonly, but the anterior element tumors are the giant cell tumors, and which has got a particular age predilection with osteoblastoma, osteoblastoma happening in the younger age groups. I would like to share with you our experience of management of navigation in the management of spinal tumors. We have three types of lesions, Group A, Group B, and Group C. But what I would be highlighting will be mainly of Group A and Group B lesions. Group A, as you can see, they are all benign tumors. Basically includes osteochondroma and osteoblastoma and osteoblastoma. This is a classical case of an osteoblastoma involving the C5 lateral mass. Usually when you want to excise, even though the tumor is benign, if you are doing it through traditional methods, it needs a wide excision, probably a need for instrumentation. By navigation, it helps you to localize a minimal access directly into the lateral mass. It helps you to localize the lesion. You can identify the tumor margins. You can do the curettage. And intraoperatively, you can rescan again to be sure that you excise the whole of the tumor. And this makes it, one of the options for osteoblastoma is radiofrequency ablation. What we use in our practice is basically navigated excision. In tumors like osteoblastoma, which are much more aggressive, navigation helps in identifying your tumor margins so that you are sure that you have done a wider resection of the tumor per se and helps in pedicle screw placement. One more interesting case of an osteoblastoma in the anterior aspect of the vertebral body, just adjacent to the cord. By using a navigation, as you can see, we could, through a transosseous tunnel, we could identify the lesion. It was curated out under the microscopic control. And then we had packed it with allograft after confirming that the osteoblastoma is completely excised. Again, a case of osteoblastoma. Osteoblastoma could be two types, the sclerotic type or the lytic type. The lytic type is much more commoner, which needs a wider resection, whereas the sclerotic type can be treated like an osteoblastoma. The differentiating feature between this and osteoblastoma is the size. If it is greater than 1.5 centimeters, it's an osteoblastoma. And this we approached through a transpedicular approach, through bilaterally, made a track using navigation, approached it, and anteriorly it was curated out, confirmed with intraoperative CT that we have done an adequate resection. And this is the follow-up at 60 months with no new formation of the tumor. One more example of a sacral osteoblastoma where you can localize and excise. And the use of navigation in osteoblastoma with what we have published. When you look at aggressive and malignant tumor, the management depends upon the extent of the disease, oncological control, pain relief, restoration of neurological function, deformity correction, and stabilization. Therefore, in aggressive and malignant tumor, you can use navigation to pass a pedicular screw, which may not be necessary in all the scenarios. But however, it helps us to plan the resection to a large extent. Okay, but you cannot predict the chances of recurrence, but it helps us to plan your surgery that intraoperatively, you can localize as to whether you have excised the overall extent of the tumor, whether you are able to get the safe margin and do the reconstruction. Here, the usage is not in overall excision of the tumor, but planning your total resection, whether you are doing a global or a posterior approach. Few examples of the case of a L4 giant cell tumor and a sacral GCT which were initially treated with denosumab. As you can see, after giving multiple denosumab, there is sclerosis of the lesion, and they later went on to have a wide resection, including sacrectomy and reconstruction using a iliac screw approach. One more example of a chondrosarcomas. You can use, basically the use of navigation in a malignant tumor is basically to plan your resection, and the chances of survival depends on your resection, your chances and the aggressiveness of the tumor and whether it has already caused a tumor spread. The efficacy of navigation system in tumor surgery has been shown in the published literature. The advantages being placement of screw, it helps in the higher likelihood of getting a negative margin resections and also reduces the chance of recurrence because of the wider safe resections. Why do people do not use navigation in their practice? Except for the main reason is the availability and the cost. Otherwise, all of us would find easier to use navigation because it makes your life much more easier and reduces the chances of complications like misplaced pedicle screws. To conclude, navigation is an important tool. It helps in the management of benign tumors to help us to localize and excise the tumor, and by doing intraoperative navigation, we can avoid the chances of doing an incomplete removal. Whereas in aggressive and malignant tumors, it helps us to plan the tumor margins, safe resection, a wider resection, and a tumor-free negative resection. Thank you very much.